Very much, Michael. My name is Gerche. I'm a cardiologist and researcher at the Behr Heart and Diabetes Institute, and I'm here with Michael Emery from Cleveland Clinic in the US. And so we've got two debates. I think largely I'm responsible for the first and Mike for the second. The first debate is about an athlete with an ICD, no way back to competition. I'll present a short case, and then we'll have a debate on whether the athlete should be allowed to return to competition between Professor Rachel Lampert and Professor Sanjay Sharma. So I shall get started with the case. Just allow me the ability to share my screen, or lack thereof ability. Now, I'm hoping I'll get a bit of feedback that you can see the screen there. So this is initially a very simple case, a elite 26-year-old Australian rules footballer who really has not had any medical problems, any complaints, no family history of any medical problems. He has the slight bad prognostic sign of being an extremely nice person. And then we'll go straight to a video. Now this goes on for a little bit, but they'll play a replay in just a second. Now at the top left of the screen, okay, so I think hopefully you picked that up. It was hard to detail exactly, but at the top left of the screen, you could see this footballer. For those of you not familiar with Australian rules football, it's a high contact sport, but also a very physical aerobic sport. They're very fit athletes. And you'll probably see a lot of similes with the high profile case of Christian Eriksen recently. In this situation, the athlete had just run back from a play and was slowing down, and then just collapsed without any warning with essentially a sudden faceplant. Now, from the ground, he was taken immediately to hospital. He was noted in the ambulance to have frequent ventricular ectopics. He had an echocardiogram in hospital, which they thought there might have been some mild basal septal hypokinesis, but essentially otherwise a normal echocardiogram, and he had a normal ECG other than those ectopics. Here's his ECG here. Leave that there just for a moment. And then I was contacted soon after the game, saw the video and was alarmed. We brought him in the following day for some testing, and he had a stress echocardiogram. The echocardiogram and the exercise component were not dramatic in any way, but as you can see here, he had very frequent ectopy and couplets, and at times with differing morphologies. He had a cardiac MRI scan, and which again showed essentially normal cardiac structure and function. You can probably see, I'm not sure whether you get to see my arrow here, but there's some little blue arrows identifying some mid-myocardial epicardial linear scar, which is quite reasonably subtle, but seen in both the long and the short axis, and is abnormal, the significance of which we can work through. He then went on to have an electrophysiological study, which was quite reasonably dramatic. He had some isoprenolone, which caused almost storms of arrhythmias, and periods of non-sustained ventricular tachycardia. Now, he then went on to have a subcutaneous implantable cardiac defibrillator. There was, again, on careful appraisal, nothing suggestive on his personal nor his family history. And he had a normal biopsy. He was started on some nadolol. And the question here was whether he can return to sport. So after that brief presentation, I think this is the point at which we can hopefully get you to vote in the poll. And the simple vote is, would you allow him to return to sport after this event with those findings with a defibrillator? And then, as I understand, we'll move directly to a debate on the topic as to whether athletes should be allowed to play with defibrillators, and more specifically whether this athlete should. And I shall introduce our two speakers. I presume I'll now stop sharing this screen. And basically, in the blue corner, I'm told that Rachel will not accept being in the red corner. So in the blue corner will be Professor Rachel Lampert from Yale Medical Centre and from the electrophysiology department. And in the red corner, we have Professor Sanjay Sharma. And Professor Sanjay Sharma is going to be speaking first, as I understand, on the taking up the affirmative that the player should be able to return to sport. Of this pie chart is that approximately 1/3 are saying yes, the athlete should be able to return to competition, and 2/3 are saying no. Am I correctly interpreting that? I need a new pair of glasses. I've got a very small, but I think that's correct. So we've got 1 in 3 of our audience saying that the athlete should be able to return to professional football and continue to earn his $250,000 a year, and 2/3 are saying that he should become a barista. Good. So let's hear from Sanjay and from Rachel and see if we can change that poll at all.
Well, thank you very much, Andre. I'm going to be arguing that this person should not go back to competitive sport. Sport makes the world go round, and competitive athletes are a source of great joy and amusement to our society, and we've noted that during the COVID-19 pandemic. However, the death or the sudden cardiac arrest of such an individual also causes immeasurable sorrow and grief that can affect the nation and the entire globe, as we noticed with the Ericsson saga during the European Football Championships in August. Most of these individuals, young individuals particularly, die from diseases that affect the electrical system or the muscle of the heart. And we know that exercise is a particular trigger for cardiac death in these individuals. Indeed, individuals who exercise regularly with these substrates are around 3 times at greater risk of suffering a sudden cardiac arrest. And with some diseases, such as arrhythmogenic cardiomyopathy, this may be as high as 6 times. We have several treatments that are available to us, including lifestyle modification, drugs, abolition of outflow gradients, and ablation. However, we've got to be mindful that the actual underlying substrate remains permanent. We can't get rid of the substrate. And it's for this reason that the American and the European guidelines have been very conservative about sport in such athletes. Our guidelines are homogeneous, they're conservative, and the aim really is to encompass all preventable deaths when one considers how much effect they usually have. I understand that this will ultimately affect athletes who may have continued to exercise without ever experiencing a sudden cardiac death. Now, over the past 3 decades, we have noted that an implantable cardioverter defibrillator is a very effective therapy in restoring sinus rhythm in individuals with potentially fatal ventricular arrhythmias. Most data, however, is derived from sedentary individuals who are aged over 60 years old with moderate or severe left ventricular dysfunction. And the best results come from ischemic cardiomyopathy, a condition that rarely affects young competitive athletes. It's actually unclear. In fact, I can tell you that the FDA, I don't think, even thought about approval of an ICD for competitive sport. There are no trials examining the actual impact of chest wall collision on defibrillator dysfunction, or any trials, animal studies, etc., examining the efficacy of the defibrillator during metabolic derangements. I'd like to impress upon you that ICDs may not be as effective during vigorous exercise compared to the sedentary state. An ICD shock may actually potentiate more fatal arrhythmias or convert VF to asystole. And in some cases, pathological substrates are accelerated by exercise and would result in further shocks, which may cause further deterioration of ventricular function. Let's take point one. This is data from over 10 million marathon runs in the United States. These are the sudden cardiac arrests, and I'm showing you that only 29% of people survived. Now, obviously, the survivors were much more likely to have CPR. They were much more likely to have emergency services attending to them, and they were much more likely to have a shockable rhythm such as ventricular fibrillation. The researchers had full data in 31 of 59 runners who suffered a sudden cardiac arrest. Of these, 50 arrests involved runners with definite or possible hypertrophic cardiomyopathy. Here is a pie chart showing you survivors in red and non-survivors in blue. And you will see here that not a single person that had a cardiac arrest with hypertrophic cardiomyopathy or probable hypertrophic cardiomyopathy survived. Indeed, the survivors were about 20 years older than the non-survivors, suggesting that pathological substrates like hypertrophic cardiomyopathy may not be amenable to good shock therapy in the presence of dehydration, adrenergic surges, electrolyte imbalance, or acid-base disturbances. Let's look at the data with catecholaminergic polymorphic ventricular tachycardia. This is a single center study of 14 patients who received 140 shocks in total, of which 75 shocks were appropriate. 43 were due to ventricular fibrillation, 23 to polymorphic ventricular tachycardia, and 3 to bidirectional VT. The cardioverter defibrillator converted all VF successfully. However, it had no impact on polymorphic VT or bidirectional VT. So none of these people could be converted successfully. We know from animal studies that individuals with desmosomal mutations are more likely to develop worsening of their phenotype. And since then, there's been a plethora of human studies that show that endurance exercise and high intensity exercise is associated with lower age at presentation, higher risk of ventricular tachycardia, and more rapid progression to heart failure. Now, Rachel will present a very elegant study that she chaired and was a PI for, and I'll only show you the first study of 372 athletes with ICDs. These are individuals who chose to continue to engage in exercise and competitive sport. They were young, 24% were under 20 years old. The main diagnoses were long QT syndrome, hypertrophic cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. The median follow-up for this study was 31 months, but there has been another study adding another 2 or 3 years. There were no deaths during this time, no resuscitated arrest arrhythmia, and no injuries due to shock. There were more shocks during activity versus rest, but there was no difference between competition and other physical activity. The lead survival was also excellent, 97% at 5 years and 90% at 10 years. When I read this paper, I put it under the microscope to look at things in more detail. I was particularly interested in the cohort of interest. This is a young competitive athlete. In this study, only 60 individuals, that's 60%, were actually truly young competitive athletes. 75% of these individuals had an ICD for primary prevention, not because they'd survived an out-of-hospital cardiac arrest, but because they were deemed high risk. Let's look at the data sets from people who've got an ICD put in for primary prevention for hypertrophic cardiomyopathy. You'll see that the annual discharge rate is only 3.6% in these individuals. Now, in Rachel's study, only 15% of people had hypertrophic cardiomyopathy. Therefore, in the time that she was monitoring them, you'd have only expected 1.45% of those individuals to actually have had a shock. So it's not surprising that nobody got a shock in the time that the people were being assessed. 47% had long QT syndrome, and we know that 62% of these athletes were beta blocked. Let's look at the data at the time of first cardiac arrest in people with long QT syndrome. only 0.3% per annum with long QT1 and 0.6% per annum with long QT2. So this study was not powered to show the true effect of exercise on long QT syndrome. Only 10%, that is 6 athletes, had diseases where vigorous exercise can truly harm, such as ARVC or CPVT. So a very small proportion of the people that we really worry about with defibrillators. 28% of these athletes received shocks. 50% of these athletes had inappropriate shocks due to supraventricular arrhythmias or oversensing. And after the shock, the psychological effect was such that 40% stopped competing completely or dropped one sport. Based on this, and these are the most liberal of all guidelines, the European Society of Cardiology decided that there should be some shared decision-making process that should be considered during decisions relating to continuation of intensive or competitive sports participation in individuals with an ICD, taking into account the effects of sport on the underlying substrate, the fact that intensive sport will trigger more appropriate and inappropriate shocks, the psychological impact of shocks on the athlete patient, and the potential risk for third parties. You saw what sudden cardiac arrest looks like in that video. I think if I was at the turnstiles watching that video, I would not allow that athlete to risk his life again. Thank you very much. An ICD should not be recommended as a substitute for disease-related recommendations when these mandate sport restrictions.
All right, thank you very much, Sanjay. Very compelling arguments there. So I'd like to invite to the platform Professor Rachel Lampert from Yale to explain why he should be allowed to return to the competitive field.
Full screen. Yeah. Okay. Disclosures. So as of 2005, I think most experts would have agreed with Sanjay that athletes with conditions that result in cardiac arrest are treated with an ICD and cannot participate in moderate or high intensity competitive sports, but they may engage in 1A. And this is from the 2005 Bethesda Conference eligibility recommendations. So what are these 1A sports that we're going to consign our ICD patients to? Well, 1 and A represent the increasing dynamic and increasing static demand of a sport. And the 1A is obviously the lowest of each: billiards, bowling, curling, golf, riflery. And until quite recently, our elected leaders chose to participate in these sports, although we finally have a little bit more active leader. But many of our patients prefer the more exciting sports. So why was it that the experts in 2005 made these recommendations? At that time, there were no data at all. And like Sanjay, they questioned the postulated risks. Would there be an increased likelihood of ventricular arrhythmias during sports? Would the ICD be able to terminate ventricular arrhythmias during sports due to all the perturbations of sports that Sanjay talked about? Would there be a risk of injury due to a syncopal arrhythmia or shock itself? The player goes up for the basket, the device goes off, he falls on somebody else, everybody gets hurt. Would there be damage to the ICD system, the leads, or the generator? However, there are downsides to athletic restriction as well. We know that active kids do better in life. They do better in school. They engage in less risky behaviors. They do better as adults. And then they go on to have children who are more active and more successful as well. And there are so many characteristics that we want our children to have that organized sports build. This study looked at quality of life in athletes who had been restricted from sports. These were not cardiac athletes, cardiac conditions, just random orthopedic problems. But while the athletes in general had the highest quality of life, both physical and emotional, the athletes who had been sidelined had lower quality of life even than the sedentary college students. This study looked at, this was a qualitative study that looked at adolescents with defibrillators, and the presence of an ICD was the most commonly reported negative impact. The inability to participate in sports was the most commonly given reason for distress among these adolescents with implantable defibrillators. And here's a quote from one of them. When I was younger, I was told I couldn't do sport. It really affected me. I was into sport. Every kid runs around. I was bawling my eyes out. I hated the doctor. And the mom says, you see her cry and just say, my life is over because this one thing I like doing and it's taken away from me. And so it's not a small thing to restrict an adolescent from sports that they enjoy. Further, restriction is not necessarily benign either. While we would like to think that we restrict our athletes from sport and they all join the chess club, in fact, what's probably more likely is this. They're playing video games, and this is a great series from John Skinner in New Zealand, new diagnoses in 3 children who actually had cardiac arrests due to playing video games. So what were the data at that time? At the time of the 2005 recommendations, there was really no data whatsoever. And again, the restrictions were based on hypothesized risks such as those described by Sanjay. So as a first step, we did a survey just to get a sense, were athletes out there doing sports? How were they doing? And this came out in 2006. What we found was that most physicians had at least some patients in their practices who were doing competitive sports, contact sports, vigorous sports with their ICD. And at that time, we asked them to report any adverse events, and they really didn't report any significant adverse events due to play with an ICD. Now, this type of survey is highly biased and limited. Who answers it? Who chooses to answer? What do you remember? But it did tell us that there were athletes with ICDs who were continuing to participate in sports, and that therefore a prospective registry would be both feasible, people were out there doing it, and ethical, because we wouldn't be asking patients to do things they weren't already doing that might be dangerous. So the results, so we then launched the ICD Sports Registry, both here and in Europe, both here in the United States and there in Europe. And the results were initially printed in 2013, and then the longer term follow-up in 2017. So the goal of the ICD Sports Registry was to determine the safety of sports participation for patients with defibrillators. The hypothesis was that the incidence of serious adverse events would be less than 1%, and we define that as tachyarrhythmic death or externally resuscitated arrest or significant injury, and we had a variety of exploratory aims. So the final report included 440 patients. About a quarter of them were pediatric, 2/3 were male, about 2/3 on beta blockers. And the overall group was actually about half and half primary prevention and secondary prevention. So it was not a low risk population. Cardiac diagnoses, as Sanjay has already described, long QT, hypertrophic cardiomyopathy, ARVC, and a variety of other diagnoses. The sports were basically baseball, basketball, cycling, running. And in the final report, we had 77, what we defined as highly competitive athletes. To get into the registry, you had to be competing at some level, including a league or, the Tuesday evening tennis team. But we did have 77 that were either varsity, interscholastic type of athletes. So we followed them for close to 4 years. There were a handful who did not complete the study. A few were lost to follow-up. A few developed worsening cardiac conditions. 2 patients died during the study period. One was a cyclist who died at work receiving multiple shocks, probably an arrhythmic death, but not related to sports at all. And then there was a younger player who had a familial cardiomyopathy that worsened during the time of the study and died of their cardiomyopathy. So the primary endpoints, basically we had none, no tachyarrhythmic deaths, no arrests, no injuries. And, what do you do with 0? Obviously, that doesn't mean the risk is 0. The size of the study was 440 patients, but that tells us that we can say that the risk was less than, with 95% confidence, the risk is less than 2% at 4 years, less than 1% at 2 years, based on the numbers that were followed. So patients did receive shocks. And I think this is where we're able to answer some of the questions that Sanjay started to pose. So patients received shocks for ventricular arrhythmias, also supraventricular arrhythmias and noise. And they all worked. As we saw, we had no arrests. Nobody required external resuscitation. Everyone was resuscitated who received a shock. Now, something that is important to recognize, the purpose of this study was not to ask whether sports exercise increased risk of arrhythmia. We do not have a control group of non-athletes in this study. We have an ongoing study called LIVE that will start to answer that question for a couple of these entities. In this study, we found that shocks were not more common during competition than during other activities, although they were more common with exercise than at rest. But again, the purpose of this study was really to say, does the ICD work during sports? And the answer that we found was yes. So many patients did receive shocks. Some were appropriate, some were inappropriate. Most actually did return. And so while we did not measure quality of life in this study, most of those patients who stopped sports stopped temporarily and in fact went back, telling us that while the ICD shock was, our ICD shocks are unpleasant, none of us would wish them on our patients. But for the patients, the benefits that they had to their quality of life from sports participation outweighed the negative impact of the shock, because most of them did go back. And I think if anybody among us probably have had painful injuries due to sports, I know I have. And while it was a painful injury, I went back and I would picture that an ICD shock from the psychological perspective is similar. So there were a couple of patients who did require multiple shocks for termination, some of these during competition. And to note, these were patients who had either idiopathic VTVF, coronary disease, CPVT, and ARVC. And we will get back to that in a moment. Characteristics associated with appropriate shocks during sports, actually in this group, more of the older patients than the pediatric, again, idiopathic VT and ARVC. And I suspect these idiopathic VFs were probably missed CPVT, and we'll talk more about that. So this was a sub-analysis of our college students. Basically, since no one had any adverse outcomes, the college students didn't either. But we did want to demonstrate or describe who these patients were that were in the study and talk about some of these the most highly competitive athletes, and they all did well in addition. So the limitations of this study, the patients were self-selected. We didn't have, as with any study, we didn't have a control group. The follow-up was limited. But shocks were not rare during sports. We did see arrhythmias. But the ICD always worked and patients returned to sports despite their shocks. So for the, Sanjay shown us the European recommendations. This is the US version of that. Basically, participation of sports may be considered a class 2B, given the shared decision-making that Sanjay discussed. So this doesn't mean that all athletes with all ICD should be participating in all sports. We did have soccer players, basketball players. This patient would have fit, Andre's patient would have fit this group as far as his sport. We did not have American football. We did not have many. We had just one or two really violent type of sport participants, American football, hockey, et cetera. And so whether the risk of device damage would be higher in these sports, we just don't know. And that's something you have to talk about with your patient. Now, this is to the getting to the places where I think Sanjay and I actually agree. What about all diagnoses? So I'd like to again bring up CPVT. With idiopathic VF were some of the patients that required multiple shocks, and our known CPVT patient. And I suspect again that these were patients who had perhaps missed CPVT, which, as we know, is can be hard to diagnose. There's a little bit. There is a little bit of data on sports participation for in patients with CPVT. This is a very small series from the Mayo. Showing that these were very well-treated patients with beta blocker, sympathetic denervation, and in this very small group, they did okay. Following that small series from the Mayo, editorialists were cautiously optimistic about sports for CPVT, but I think we do have to be very careful because inappropriate shocks or any shocks in CPVT can precipitate VF, and the whole thing can then become a vicious cycle in that entity. In Andre's case, there was one ECG that looked like there were two PVCs that were perhaps bidirectional during exercise, although he later describes 10 different PVCs, which doesn't sound a lot like CPVT. So I think for this particular case, probably not CPVT, but I think perhaps some genetic testing might be helpful as well. Similarly, we don't know for sure whether this patient has ARVC. Again, hard to tell from what's given. Certainly, there was no morphologic evidence pointing towards ARVC on the MRI. And as Sanjay discussed, we do know that sports can perhaps worsen things in ARVC. So again, I think need to make sure we know what the diagnosis is, because this particular patient probably does not have the ARVC, but again, ruling out a P2 mutation, some of the higher mutations would perhaps be helpful as well. So I'd like to just spend a second talking about how do we make the decision, and the importance of shared decision-making, which is now explicitly noted in the European guidelines as well as the HCM guidelines. The US document doesn't use that phrase, although it does support that concept by this concept of that sports may be considered. So this was first discussed by Johnson Ackerman, or first described by Johnson Ackerman in 2012. It was a series of 157 competing athletes who came to the Mayo Clinic. And they went through this very comprehensive time talking about the risks and the benefits, the evaluation. And one of the most important statistics I took away from that series is the fact that 130 chose to continue, not 157. So this was a real shared decision-making conversation that was going on. It wasn't just a doctor saying, sure, no problem. So I think while the word shared decision-making, the phrase, is something that's sort of become increasingly fashionable, in fact, the concept has been going on for a while. This is a paper by Ben Levine that was written, I think, in 1980s or something, that talks about the assumption of risk, the individual assumption of risk. And all of our highly competitive athletes, our 77, were all doing something that was against the guidelines at the time. And while we don't know what conversations went on between each of these athletes and their physicians, there has always been a concept of thinking about risk and the fact that individuals think about risk in different ways. So how do we talk to the family? How would we talk to this patient about returning to play? So we talk about what are the data. We talk about the study that I described. What are the limits of the data? Well, we had 440 patients. We didn't have 400,000 patients. Was that athlete typical of the athletes in our study? Well, yes, half of them were secondary prevention. He plays a sport, the soccer, that we had quite a few of. And so I think the data would apply to this patient, again, with a caveat that we don't know 100% what his underlying diagnosis is. I also talk about how to think about risk. I talk to my patients about the concept that thinking about risk is difficult. This guy here was awarded a Nobel Prize for the concept that thinking about risk is hard. And I think it's something that doctors have known for a long time. And I talk to families about a spectrum of comfort with risk. So I talk a lot about this girl who sailed around the world at age 16. Now, obviously, she didn't buy this sailboat herself. Her parents must have been quite with the program for her. I personally, my daughter's now a little older. She would not have been sailing around the world by herself. So that was a family with high risk tolerance. What about American football? So as the data are accumulating about the dangers of American football, some families do and some don't allow their children to play. So I think people need to think about how risk fits into their life. As I was preparing for this talk, I went back and I think the first written debate I had on this was in 2008, although I think I may have had some oral debates prior to that about whether to allow these athletes to return to play. At this point, we have the data. Could we get more? Of course, there's always room for more data, but the data we have is pretty good. In July, I gave a talk at HRS supporting sports in the pediatric patient with ICDs. And I think it's time to move away from the debate and into supporting sports for these patients. Thank you. And thank you to our sites that participated in the ICD Sports Registry.
Thank you very much, Rachel. So at this point, you've heard two opposing views, or largely opposing views, and I would ask you to go to, I think, the chat part of your screen, and there should be a link there to again vote, and we'd be interested to see whether that has changed your opinion. We had approximately 1/3 saying that they'd be happy for the athlete to return to sport, and 2/3 saying that they would not. So I'd ask you to vote. It takes a while for the results to come up. I might steal some of that time to actually address a couple of questions that have come up, or comments and questions. One I might list just as a comment, with someone saying that they were surprised about the durability of the leads in the study, and that that in their opinion, 10 years and the leads would no longer be working. I might leave that just as a comment. And then the one I would ask for a comment just quickly, perhaps from both of you before we get into a quick rebuttal. Any difference in approach from a subcut device, which our athlete had, versus a more traditional device with transvenous leads?
I'm sorry, Andre, you asked about the subcutaneous device?
Yeah, would that have any impact on your decision for return to play versus
I think
the
there's a
more
lot of
traditional
speculation. I
transvenous?
think there's some sports in which the subcutaneous device is probably better, things like rowing and swimming that are heavy use of the arms. We actually looked at that. We published on the what predictors, and we didn't actually find that, but there weren't really enough of different subgroups, I think, to know for sure. My own feeling is that in a contact sport, you're probably better off with a transvenous. I think that a box here, which is underneath the padding, the lead is inside of your thorax, is perhaps safer than a box which is here and a lead with really nothing between it and a ball that would smash it against the ribs. But I think we don't know the answer. And actually, a study is just starting. Sammy Viskin is the PI that will be a registry of athletes with subcutaneous ICDs, and will hopefully give us more information on that question.
Okay. So we had the results that popped up there for a moment, and really it would seem that we've had very little shifting of the dial. We've got 36% saying that you could return to sport, and 64% saying that no, he shouldn't, which my recollection is almost identical to pre. So we've either got very stubborn recipients or very valiant attempts at persuading people with not much effect. Now, I think we've got time for 2 minutes without any slides, but a quick rebuttal, starting with yourself, Sanjay.
Okay, can I go?
Yes.
Okay, well, thank you very much, Rachel, for that very interesting talk. And you can see this was a very unfair contest because Rachel spoke at least 3 times longer than I did. But nevertheless, I am very pro sport and exercise, and I believe that everybody should do exercise, and I wouldn't want to take that away from anyone. But we were talking about competitive sport with vigorous exertion where people are achieving more than 80% of their maximal heart rate and giving their all. And in Rachel's study, and I agree it's the only type or one of its type, there were very few of these in that study, and this study really wasn't powered enough to assess the precise efficacy of the ICD during sport. I maintain that deaths in sport are unpredictable. Look at Christian Eriksen. He was competing since he was 17 and he has a cardiac arrest out of the blue. The same with Marc-Vivien Foe. And these triggers vary from day to day and cannot be predicted. An ICD, which Rachel conceded, does not prevent deterioration of ARVC and may actually worsen it with shocks. An ICD may make things worse with CPVT. Most individuals with these conditions require medications. It's impossible to be a top athlete on beta blockers. We all know that. An ICD is not foolproof. And because of this, people who implant ICDs into sports people may actually cause false reassurance, thinking they are protected and they're going to be absolutely fine. But we've got to be concerned about litigation aspects here. You put an ICD into somebody who's got a life-threatening condition and it goes off and it doesn't work. Whose call was it to put the ICD in? Who is responsible for making that ultimate decision? Finally, the psychological impact of a shock should not be underestimated, and it could scar a young individual for life. So my play on all this is if someone's got a life-threatening condition, I would certainly put an ICD in to save them from a day-to-day basis, but it certainly wouldn't be a call for them to go back to vigorous competitive sport, although they may continue to exercise gently in these situations.
So I would contest 2 of your points and agree on another 2. So I think as far as the efficacy, we really don't have a reason to think that the ICD is not going to work. We did have shocks and the ICD worked in all of them. The only time it required multiple shocks, suggesting that perhaps it was less efficacious, was in CPVT and ARVC. One thing I'll point out, in hypertrophic cardiomyopathy, we had a lot of shocks and they all worked. The only time an ICD shock, an HCM patient required multiple shocks was a teenager who was a word we used in our paper was socializing, who was partying at the time. all of the shocks for hypertrophic cardiomyopathy, the first shock worked every time during sports. And so I think the concept that the ICD isn't going to work is just not founded on the data we have. Now, the study wasn't huge, but we did have a fair amount of patients. And in general, the ICD works well. So I think, yes, is there a possibility the ICD wouldn't work in a given person? You can never say anything in life is 100%. But as with anything, what we say to the athlete is the risk is very small. We can never say a risk is zero, but we have no indication of harm. I would also, again, point to the psychological impact. I think the psychological impact of restriction is massive. There are anecdotes of kids who have committed suicide following restriction from sports, and all our patients did go back. And so suggesting that although it's like, again, a shock is not pleasant, but at the same time, the sport was more important to them on the positive side than the shock was on the negative side. So I think I would again have to disagree with those 2 points. On the other hand, I completely agree with your points about CPVT and ARVC. I think, and this is where the may be considered comes in. Not every patient is the same. And certainly with ARVC, particularly some of the mutations that were prevalent in the Hopkins data, we really have to think about have to talk to the patient in a very different way. And so I think if we knew this patient had ARVC, I would be thinking about him differently. So I think the importance of thinking about the underlying disease is, I think, a place where we would definitely agree.
I guess I'm not allowed to say anymore, am I? Is that the end of the debate?
No, I don't think so. So I do think it's fair to say that that Rachel wins both in terms of the number of learned books in the background and in terms of the duration of speaking. But we are going to have to draw it to a close. It's actually a very interesting what subsequently transpired to that athlete, and perhaps at the end after the second debate, if there's a bit of time for further discussion, I can fill you in with what actually did happen with the athlete. But what I think we do need to, given as Michael explained at the beginning, the sort of time pressures, I think we should move on to our second debate. I'd very much like to thank Professor Lampert and Professor Sharma for a fantastic debate. Thank you very much.
Thank you.
Nice to see you, Sanjay, even across a Zoom screen.
Thank you. And nice to see you too.
Thank you all. Again, I'm Dr. Michael Emery. I'm co-chairing this session with Dr. Gerche. We're going to move on to the second great debate, which is an athlete with long QT, treat and release. We got a couple of great debaters in Dr. Behr and Dr. Castelletti taking the pro and the con, but I wanted to start with just a brief case to sort of get everyone's appetite wet. So this is an athlete with long QT. So it's a female 18-year-old competitive swimmer who had what was in essence a screening ECG done prior to participation in sport when she turned 18. You can see she's bradycardic, which would be testament to her athletic prowess, but she does have a long QTC measured in 2 different leads and twice, both around a little above 480, which would be considered abnormal by the international criteria. So she comes because she had an abnormal screening ECG, right? This is a pretty common scenario that a lot of us will see. We do what we do and we take a family history, and this is the beginning of a pedigree, and lo and behold, she actually had a syncopal spell 2 years ago that sort of went unworked up. She didn't really tell a lot of people about it, but when you take the history, it was definitely a real, true syncopal spell. And then you take the family history, which we're ought to do, and mom had a syncopal spell while skiing as well, which could be benign. Certainly vasovagal events are common occurrences, but starts to raise the possibility that maybe this long QT is a little more alarming from her screening ECG. We repeated the ECG in clinic, continues to be long, no matter how you measure it on which EKG. She underwent more risk stratification with exercise testing, showing that her QTC did not shorten appropriately with exercise. And if we look at the guidelines about measuring 4 minutes into recovery, her QTC was well above 500. She had a 24-hour ambulatory monitor with an average QTC of around 500. And then underwent genetic testing given this family history, the long QTC with exercise showing a KCNQ1 mutation consistent with long QT1. So we're going to pop up the debate question here. Would you clear this patient for sport? And then we'll get into our debate. If I can stop sharing. We'll have to wait a moment here to get these results before we get to our speakers. Here we go as it starts to come up. Hopefully get some fireworks from these debaters. A pretty substantial no vote to this point. This may beat our last debate in terms of the overall no vote. Perhaps we can get a little bit of shift this time. All right, so I'm getting around 83%. I think that's going to be pretty definitive vote so far. So why don't we, at this point, move on to our debate. Our first debater presenting the pro would be Dr. Elijah Behr. So Dr. Behr, I'll let you take it away.
Thank you, Dr. Emery, for the introduction, and thank you to the team for asking me to speak today on the pro side of this argument. It looks like I'm already onto a loser. Bearing in mind nobody changed in the last debate, I'm starting off on a low level. But I'm going to try and convince you that this athlete with long QT syndrome and a prolonged QT interval could be treated and released to return to sport. Now, first of all, I just want to address some of the exercise recommendations in athletes to the AHA-ACC document around cardiac channelopathies, and a general recommendation made that for athletes with a suspected or diagnosed cardiac channelopathy, a comprehensive evaluation by a specialist with sufficient experience and expertise with these disorders is recommended. And I want to show you why that's important. First of all, it's to do with the diagnosis of long QT syndrome. It's in the presence of a risk score greater than 3.5 in the absence of the secondary cause. And the risk score, as particularly my opponent here, who's a colleague of Professor Schwartz will know, is based on the severity of the ECG abnormalities detected, including the absolute interval, other ECG features, evidence for arrhythmia, blackouts, and other features including family history, and you score points and you get long QT. Furthermore, pathogenic mutation in long QT gene, long QT, and if you have QTC intervals over 480 milliseconds in repeated 12-lead ECGs, as in this particular individual, then you would score the likelihood of having long QT syndrome according to both the HRS and ESC guides. And if you have syncope and 460 milliseconds or above, then you could consider the diagnosis as well. So it does seem that this young woman has long QT syndrome to begin with. But having said that, we mustn't always presume that a screening ECG showing QT prolongation means long QT syndrome and imminent risk from exercise and for disqualification. So data from Sanjay and his team, lucky enough to be involved in, shows that athletes often present with long QT intervals. And in fact, if you use conventional cutoffs of 440 in males and 460 of females, 1 in 125 would have long QT syndrome. And clearly that's not correct. The population prevalence of long QT syndrome is roughly 1 in 2,000 based on population studies and neonatal studies. And indeed, athletes with a QTc over 500 milliseconds, so severe QT prolongation in our books, were the only ones who exhibited other features of the syndrome that would be compatible with long QT. What that meant, and what has been followed up by Silvia's colleagues, and I think she's on this paper, is that exercise training-induced QT prolongation may not always mean long QT syndrome. And in fact, in this really excellent study from their group, they looked at a load of athletes presenting with repolarization abnormalities, including QT prolongation. And they determined that a substantial proportion did have long QT syndrome clinically. And when they detrained, their QT intervals dropped by, on average, around 20 to 30 milliseconds. So in fact, they had longer QT intervals during training than they did in reality when detrained to the level of a sedentary person. If we look at the cases where there was completely reversible QT prolongation, they had a dramatic drop of around 70 milliseconds on average, and their Schwartz scores dropped to virtually zero, the LQTS risk score. So QT prolongation in an athlete does not automatically mean long QT, and it does not automatically mean high risk. In fact, it means we need to be very certain of the diagnosis in the athlete. And we have no evidence that the exaggerated QT intervals in athletes equate to higher risks for athletes. But what are the risks then overall in athletes and non-athletes? These are data, survival data. So we have adult data from 18 through to 40 years on the x-axis, and on the y-axis we have aborted cardiac arrest or death deemed to be due to long QT syndrome. And this is data from the Rochester registry. Relatively old data, but it seems to hold up. We can see that females have a higher risk than males, but their absolute risk is 0.5% per annum of a living event, and males is 0.1% per annum. This is in the context often of our ICD decision-making being around a treated risk of 1% per annum. Now, what about if we look at the same population but stratified according to how long their QTc interval is? A very long QTc interval of over 550 milliseconds on its own, it still doesn't quite get over that 1% per annum risk. So, and this is still in the untreated population, not on beta blocker therapy. If we look at those who have only mild or moderate QT prolongation or absent QT prolongation, the genotype positive, phenotype negative, it's as low as 1 in 1,000 risk per annum. And then if we look at symptoms pre-18, and we know that this individual had 1 syncope when she was 16, I believe, from the presentation, we can see here the annualized risk is 0.8% if you've had more than 10 syncopal episodes pre-18. If you have 0 or 1 syncope, it's 0.27% per annum. So still on the low side. And in general, this may actually appear to be lower than we would have expected for long QT syndrome, given ideas about it as a condition. So there are multiple different therapies, and I'm not going to go to a lot of detail about these for long QT syndrome. We have lifestyle adjustment involving avoidance of QT prolonging medication and the treatment of hypokalemia. We have drugs in the form of beta blockers and the use of mexilatine, particularly in long QT3, but also in LQT2. Judicious use of cervical sympathectomy as an additional therapy, and ICD therapy as an additional protective in patients who present with higher risk or who are not responsive to medical therapy. So let's just have a look at beta blockers. And these are old data again, but they stand up to scrutiny and contemporary data as well, as I'll show you in a moment. We know that beta blocker therapy is very effective, reducing risk. And from Arthur Moss's study, it's a 4 to 5-fold reduction, particularly in LQT1. And in this patient, we surmise that they have an LQT1 variant. Indeed, the breakthrough events were mainly due to QT prolonging drugs being administered and non-compliance with the beta blocker. And indeed, if we try and look at the risk overall in the population, these are recent Italian data that show a pyramid of risk, with most patients being in the bottom of the pyramid. This bit of the pyramid over here having less than 1% per annum risk from their long QT syndrome, and this is prior to treatment. If given non-selective beta blockade with nadolol, we have a dramatic reduction with a hazard ratio of 0.38, other beta blockers less so. They're clearly effective in reducing risk. And ICDs, you've already heard a lot about this, and you've seen this study already. Are they risky in athletes? Well, we've seen that the population described by Dr. Lampert had a large component of patients with long QT syndrome with a median follow-up that was reasonable, with no mortality or injuries due to shock during time, and a high lead survival rate, remarkably high, as that one commenter suggested. But what has this meant for exercise recommendations for long QT syndrome? Well, historically, they've been very, very restrictive. If you look at the slides from 2005, absolutely no competitive sport whatsoever. And that's for the cutoffs, the old cutoffs of 440 and 460. The Tester report was more lenient, over 470 and 480 being defined as prolonged. But again, 1A sports were the only permitted sports. And the initial diagram again from Dr. Lampert, 1A is right at that bottom corner, low dynamic component, low static component, certainly not swimming, which is in the, I can't even see the swimming over here amongst it, you have to forgive me. But I think we can spot it there over here with a high dynamic content and a moderate static component. There we are, just with 1A. And what are the psychological effects of such restrictions on young sporty people, on athletes? You've already heard Dr. Lampert, those scenarios that are of great concern. So let's see what data has come on there. We've already seen we've already seen Dr. Lampert allude to the data from Dr. Michael Ackerman's group of 130 long QT patients, very typical of a genotype population, 87% LQT1 or LQT2, a very large proportion of beta blockers, and 20% had ICD. Beta blockers and ICD therapy. Just over half were genotype positive, phenotype negative, so with normal QTCs or relatively normal QTCs, and 46% positive of over 500, with a 5-year follow-up equating to 650 athlete years. So not the longest follow-up, admittedly, but there were 0 events in the one group, and one patient had events in the other group, and it was the same patient who had 2 events, and this was in warming down during a basketball match, I believe that was another. And this led to a turn of consideration in the 2015 guidelines, allowing the return to play to be considered Class 2B in symptomatic or patients with manifest ECG long QT syndrome. So not the genotype positive, phenotype negative, but actually patients with long QT syndrome. How have the ESC guidelines addressed these emerging data? Well, that is already alluded to, of shared decision making, but this was applied to the genotype positive, phenotype negative group. Anybody with symptoms or manifest disease will not be allowed to participate at all, Class 3. And so the data earlier this year from Mike Ackerman's group, Return to Play Part 2, a protocol in evaluation that is very comprehensive, a customized treatment plan, a deep discussion with the athletes and review of the guidelines and the literature, this decision made with the athlete and their parent if age appropriate, and then a plan put together to return to play over a several-month period with appropriate monitoring and then follow-up consultation and reevaluation. So really, and as the initial guidelines suggested, expert management by experts used to dealing with the condition. And of their 4,000 patients, there were 494 long QT syndrome patients that were suitable for the return to play protocol. Cutting a long story short, there were no deaths in this group period. Most athletes were free of cardiac events. That's 94%. There was a rate of 1 breakthrough cardiac event on average per athlete year. Most of those breakthrough events were in non-sports related scenarios, so not during sports. My conclusions following these data are that athletes have longer QT intervals. Many with QT prolongation do not necessarily have long QT syndrome, and so we do have to be very careful how we diagnose athletes. And there's no evidence of higher risk being attributable to the additional QT prolongation that athletes have during their period. Risk in long QT syndrome isn't as high as one may think. Most patients are low risk indeed. Therapy is effective in reducing. Athletes appear to be able to tolerate beta blocker therapy and ICD therapy in those with long QT syndrome. Most breakthrough cardiac events are not during sports, and mortality seems to be very low, particularly when it's part of an expert program. And we must also reflect, therefore, on the potential benefits of continuation of career in terms of psychological benefits and how high that must be. And so I would put to you, please work, treat, and release.
Great. Thank you, Elijah. That was a great talk on the pro side. Now let's see if we can start a little fireworks on the con side. I'm going to introduce Dr. Castelletti to give us a brief presentation.
Okay, hi. Thank you very much for inviting me to debate. It is quite challenging to debate against Professor Behr, but I have some points on which I think I can win. First of all, let me tell you my disclosure. I'm not against sports, and I'm not against sports also for LQTS patients. However, I think we should not forget few important things about long QT syndrome. First of all, that the events occur during sympathetic activation, such as exercise, especially in long QT1 patients, or emotion, especially in long QT2 patients. However, if we think to exercise and to competitive exercise, we're speaking of both exercise and emotion. So a very dangerous mixture in an athlete. And we should not forget also what Professor Behr has shown us, that there is a risk of events, and this risk is higher the higher is the QTC. Look here. We start from 460, 470 milliseconds to have a risk of about also 3%. But we have not also to forget the risk of events also in those patients that have a normal QTC. Professor Behr has already shown in this paper. As you can see, those patients that have a normal QTC despite carrying a mutation have, yes, a lower risk of events compared to those that have a prolonged QTC, but yet they have a 4% risk of having a cardiac arrest that is 10% higher of those that are unaffected. And this is important because we know that the risk of having a life-threatening event first manifestation of the disease is high. We're speaking of 12% of sudden death or cardiac arrest. As Professor Behr has shown you, this risk is lower when the patient is taking beta blockers. Okay, but let's think to the effect of the exercise on QT. Professor Behr has already shown you that a lot of athletes may display a prolonged QT. Okay, but we have just said that the higher the QTC, the higher is the risk. And let's go back to the work that our group has just published and that Professor Behr has very nicely explained to you. If we look to these patients, all of them, while in training, have a QTC that is higher than 470 milliseconds. That is exactly the threshold of an increased risk of events. And let's speak also of the paper of Michael Ackerman that shows that we may have reassuring data about patients with long QT syndrome that exercise. Okay, but we're speaking of very young athletes, 11 years plus minus 7 years old. We're speaking of a study with a very high confidential interval. So the results this is a very high limitation, in my opinion, of the results. But most of all, those that are engaged in competitive sport are very few. So I'm not sure that we are speaking about competitive sports participation in athletes here. And the event that was registered in a patient with a high QTC and that was not compliant to the therapy. The problem of the adherence to therapy is quite important because, yes, we know from this study that beta blockers are really effective, especially in long QT1 syndrome, as Professor Behr has shown you. But there is another important message that we should not forget from this paper. The other important message is that 19% of those patients that are affected are not compliant with the therapy or take QT prolonging drugs. And if we look also to more deeper to this paper, among those patients that experience sudden death or cardiac arrest on therapy, the majority, 92%, were those that were non-compliant to the therapy. To be compliant to the therapy is a very important point. And more recently, this paper has shown that among a cohort of 90 LQTS patients, 51% take beta blockers in a suboptimal way. But 51, we can argue that is not so high. But if we look better, we will see that the medical possession ratio was 0 in 10% of this 51%, and was 1 that is considered very good only in 13% of those that were taking the medication in an adequate way. And if we think to the athletes, we should not forget the effects of beta blockers. Because yes, Professor Behr said that athletes may take beta blockers, but we have a lot of things that we should consider. First of all, that beta blocker reduce the heart rate, both at rest and exercise. And this can be a problem if we have to prescribe beta blockers in an athlete that is already bradycardic. Our lady is the lady of the case that has been shown is a bradycardic. So we may have some problems in prescribing beta blockers in an athlete and in achieving the targeted dosage. But also we know that beta blockers may modify the local muscular metabolic properties, can create a peripheral vasoconstriction and increase the levels of lactates, and also lower the VO2 max. All effects that impair the endurance exercise capacity and increase the perceived exertion in an athlete. And all of these may contribute in a lower adherence to therapy in an athlete. So when we are speaking of allowing a patient with a long QT syndrome to exercise, we should not forget that we are speaking of a life-threatening disease, and that sport can trigger events. We have seen this in long QT syndrome, especially long QT syndrome 1. Moreover, that sport can prolong the QT, and we know that the risk of event is correlated with the QT value, but also that sport increase the vagal tone with problems in prescribing medications, and may create an electrolyte imbalance. And we know that the reduced potassium can also trigger events. So we should be very careful also in how much exercise the patients take. And when speaking of the therapy, yes, beta blockers are really effective in long QT syndrome, but what about compliance? And what about compliance in an athlete? And also, what about the dose? What about the possibility, the true possibility to prescribe a beta blocker in a patient that is already bradycardic? Would you still allow a long QT syndrome patient to exercise? Curious to know. Thank you for your attention.
Thank you. Those were a couple of great talks. We're going to slide back into the same question we had before. And in this case, after this debate, would you now allow this athlete from the case presentation to play sports or not play sports? So it's going to take us a moment to get that all wrapped up while we invite our two speakers back, Dr. Behr and Dr. Castelletti. We'll each let them have a little bit of a brief rebuttal, and then we'll get to some of the questions.
Well, I'll go first then, I think, since I started.
I think we're waiting for the results of the poll.
Would you like to have that before before comments?
All right, so they're telling me let's move on. So let's let you have a little brief 3-minute rebuttal, Dr. Behr.
Sure, I'll try and be brief. I've made some notes because I think Silvia's talk was excellent and touched on a lot of great points. I think my overall feeling about patients like the one we've seen is it's a balance of risk, and it's a balance of risk versus benefit. And if we do the evaluation in the setting of expert clinics, and we give all the due attention to the various factors that Silvia raised, including compliance, isotonic rehydration for hypokalemia during exercise, all these aspects that are really important to address, that we can make therapeutic interventions for the patient that are going to reduce their risks significantly, and they can judge that they can be released to return to play. Now, it may not be that they're always going to return to play as an NFL athlete or a Premier League footballer, but they're released to return to play nonetheless and have some of their life back, if not all of their life back. So that's one point to make. And there are lots of other factors that we need to consider as well. I mean, one, for example, is the issue of compliance that Silvia raised, which is extremely important in young people, of course. But also, we know that at her center in particular, there's a really strong emphasis on the use of denervation surgery and sympathectomy to very effectively treat patients who are not responsible, compliant to beta blockers and who are not able to take beta blocker therapy. So I think there is a valid therapeutic option for those patients as well that can be really effective. She also talked about the genotype positive, phenotype negative group and stopping them from participating. But just remember that that slide was 10% risk of sudden death and cardiac arrest due to long QT syndrome over 70 years of life. And we just need to bear that in mind. We're balancing the risk for the individual compared to stopping them from having their sports life over that whole period of their lifetime. Furthermore, the more updated Ackerman data is a lot more patients with a lot more follow-up and a better range of sports, including higher dynamic and static range sports. And I think that gives a more realistic representation. Patients are having therapies and shocks, but they're not dying from them. And they're not dying from long QT. They are managing to get on with their lives and play sport, and only 4% were suffering from breakthrough cardiac events. But nonetheless, it appears that I have lost. She has come, she has seen, she has conquered.
Well, but you have done very well because you have increased the number of people that would allow LMQT patients to exercise. I more or less agree with most of your points, to be fair, because I also think that if we are not speaking of competitive sports, we may discuss the possibility to exercise. However, let me just make one point. First of all, we're speaking of a very young lady, and I think that if we should consider also that low percentage of risk to experience a life-threatening event. And about denervation, yes, we are the first group that proposed denervation as a antiarrhythmic therapy in those patients that are not taking beta blockers. However, if we look to the studies demonstrating the antiarrhythmic effect of denervation, if we look to those patients that had repeated adverse events, are those patients that were not taking beta blockers. So again, unfortunately, therapy is really important in this disease. And if we cannot be sure that the patient is treated with the right dosage or is taking it correctly, or has not other factors that may increase the risk, such as QT prolonging drugs, or that has an imbalance in electrolytes, then I think we should be carefully in prescribing exercise, at least at competitive level. Then for the rest, of course, I agree with you. We are speaking of a young lady, and exercise is important. As I've said, I'm not against sports, but let's be careful.
Great. That was a great debate. We can see that when the final poll came in, there were 59% now that would say no as compared to the 88% that we started. So I'd call that a statistically significant shift into a tie. And now we'll use shared decision-making to decide how to break that tie. So at this point, we're going to invite all four speakers back for a brief 10-minute Q&A from some of the audience questions and any other comments that we may have. So we have Dr. Sharma and Dr. Lampert back.
Yes, we're here.
Yep.
So I will start with one of the questions from the Q&A. One of them was, how reliable or diagnostic is QT assessment and Holter monitoring in individuals with borderline QT?
I don't know who wants.
Dr. Castelletti, why don't you take that one for us?
Okay, so the question is, because I cannot hear very well, how reliable is the 24-hour tape in the QTC measurements? Is that correct? If so, I can say that is important that the 24-hour tape is a 12 leads 24-hour Holter monitoring, because this allows to see all the leads of DCG. And as we know that sometimes there are some repolarization abnormalities that can be seen in the precordial leads. So it's important to have a 12 leads. That these repolarization abnormalities may be present during the night. So it's important, the 24-hour tape. But the most important thing, in my opinion, is that the measures of the QT interval are performed manually by an experienced doctor or cardiologist, because sometimes the automatic measurements of the 24-hour tape may under or overestimate the QTC calculation. This is in my experience. I don't know whether Professor Behr has something to add.
Yeah, I certainly don't use the Holter monitor myself to make or a diagnosis, only in very specific circumstances. As you said, the averaging done by the computer-based systems is really poor, particularly those based on the 3 or 5 lead Holters, where you're just relying on the lead view of the ECG. They can still give you some ideas, of course, around T-wave alternans and pause-induced abnormalities that would suggest long QT, but there's a good reason why it's not in the short score, because it's not reliable enough to be used in a systematic way across all sorts of services. Of course, 12 lead Holters being used in a specialist center who knows how to use them is a very effective way of looking at them as well.
And then we have another question from the audience, which is almost a lecture in itself. What is the impact of genetics? How does it affect our management? I think perhaps there was someone take that on in a short answer.
Andre, there was one point that was interesting, though, that I forgot to make. It may not have earned me any extra points in the debate, of course, but it is interesting that we should also take into context the genotype, of course, the mutation. You've already heard that genetics is useful. LQT1 may be more strongly associated with swimming-related risk and exercise-related risk. And clearly Silvia's concern for that patient in particular. But also we have to recognize that certain mutations are going to be worse than others. And if you have a splice site mutation causing a non-dominant negative effect, then that makes you be a milder phenotype in truth. And so when you detrain that girl, she may actually drop her QT by 30 or 40 milliseconds. We don't really know what that extra QT means anyway in terms of outcomes for athletes with long QT. But I think we do have to also know what we also have to take a view on the biophysical effects of the mutation and therefore add into the equation of how you manage the patient. So we may actually think this patient is a bit less at risk than initially thought.
Can I dive into another question? I'm just said there's a few other questions from the audience, but just to broaden it up because they're very QT related, but to bring in also the first debate. Can I just ask, one of the themes that came up was that maybe it'd be okay to let these people compete at a sort of leisure sport or kick around the park, but not play at Wembley. given that what we've seen with some of these athletes when they are playing in a major stadium and someone rushes out with a defibrillator and saves their life, would it not perhaps even be safer to be saying that it's okay to play as a professional, but there's some problems in just kicking around at the local park? I guess putting another spin, but I'm just wondering whether that's very sound advice when we're sort of putting these grades on exercise. Do we have any opinions? Maybe should we start with Rachel?
So I think it raises a couple of questions, Andre. From our data, whether competitive sports at any given moment is really higher risk than recreational, I don't think we know the answer. We always look to the sort of the famous cases, and while there are some famous cases going down in the middle of high intense competitions, but there's also lots of situations in which the famous athlete actually dies in a pickup game. So I'm not really sure whether there is a meaningful distinction there. I actually think that the way catecholamines play into arrhythmias is that at the time that you are most active, most highly adrenergically activated is probably when you're going to have your arrhythmia. So if you're a competitive athlete or a marathoner, that's going to be when you're performing competitive sports or a marathon. If you then dial it down and you become a recreational athlete, well, then you're going to die during recreational sports. Similarly, if you cut it way down and you're sedentary, you're going to die running for the bus. And I think we see that in the paradox of exercise in the general population. That's really what that means. It's really not a paradox. It's really about the way the autonomic nervous system interacts with arrhythmias. So for me, I don't really see that distinction as highly meaningful.
Can I make a point there as well, Andre?
Yeah, absolutely.
Yeah, I mean, depending on the condition as well, many of these deaths are not occurring on the sports field or during exercise. They're still occurring at home or in bed, particularly if you're thinking of the channelopathic disorders, other than, of course, CPVT. So I think we can't sort of delude ourselves that restriction in sport is going to solve the problem for these patients.
I would just jump in. I think the one situation, again, where there might be a difference is ARVC, where the amount of exercise directly impacts the load on the RV. But I think for the other, where we're really talking about catecholamines and demand and that kind of thing, I do think ARVC might be an exception.
Yeah. I'm always just a little bit struck that when an athlete does have an event during sport, there's kind of an assumption that if he didn't play sport, that event wouldn't have happened. It might have happened that day, but it might, I think it's a very, as you said, Rachel, it's one of the unknown things, the efficacy of suspending someone from sport. And it's going to be hard to solve completely. Unless I'm just watching quite closely. I think that we're pretty close to needing to wrap up in terms of time. The only problem with that is perhaps someone else can explain what time we're going to be returning back to the next session, because I'm so confused with my time zones over where I am that I'll defer that perhaps to Michael's expertise.
I'm going to squeeze in one last question. At least, and it's one that's come up multiple times, and that's the initiation of beta blockers in athletes that already have, vaguely mediated baseline bradycardia. How do you initiate beta blockers in them if you're going to do that as a treatment? How low do you push their heart rates, both at rest and with exercise? Is there ways to monitor that? And how much does it really affect their exercise capacity? So I'm going to ask Dr. Sharma about that, because he brought that up initially in his presentation.
Yeah, I mean, it's very difficult to prescribe a beta blocker to someone who's got a baseline heart rate of 45 beats per minute and Mobitz type 1 second degree AV block and sinus pauses in their sleep. You've got to be pretty brave to start large doses of beta blockers, the sort of doses that are supposed to be prognostically relevant in this group. So that's point number one. Point number two, of course, is that there is no doubt that beta blockers will affect your functional capacity, because you will have to work much, much harder to get to that peak heart rate that you're used to getting. When we tell athletes, that you're now beta blocks, and when we exercise them, they really struggle to get heart rates beyond 85%. I mean, I'm using 85% because I think anyone who's excelling in sport, and we've been talking about competitive sport here, should be able to achieve a max heart rate of at least 85% to do their job properly. So that's one of the concerns I do have, when we were talking about the ICD debate, that yes, put an ICD in. And of course, I'm pro ICD for primary and secondary prevention, and also very pro exercise. But if we're going to make someone a competitive athlete and throw a beta blocker on as well, the question really is, are they now still competitive? That's the question. Can Andre Le Gerche do a marathon on a beta blocker that's 3 hours, 4 minutes? He probably can, but let's call it 2 hours, 50 minutes or something.
I can, referring back to the cases, I can tell you that the first case we treated him with 80 milligrams of nadolol, which he was taking as a 40 BD dose for what it's worth, but pretty hefty dose of beta blocker, and was feeling unimpeded with exercise. So it is interesting sometimes how well it is tolerated, but I agree that's not in every case. Now, I was jumping the gun with the questions, but with calling a close, because we've got a bit more time. The other question that came up is, what should we be following when we start the beta blockers? How do we follow the efficacy of the beta blocker?
I think an exercise.
Should we be following? Do we have a heart rate endpoint? Do we have a QTC endpoint? Sorry, Sanjay.
I would agree with Sanjay. It's the exercise test that's going to help here, and it's really the degree of blunting of heart rate response. I don't rely on there being a reproducible QT reduction. That I think the only time I would expect to see a QT reduction is if we're using maxillatine as well in an LQT3, LQT2 patient, where you might see that effect. But with beta blockers, I think we're looking for the effect on heart rates and comparing the peak heart rate pre-beta blocker to the peak heart rate on beta blocker. And I suppose I start to feel that somebody's adequately treated if they can't get above the 85% that Sanjay specified. So I would say around 75%, I'd feel okay. I could be happy to leave that patient alone, provided, of course, they're not a child who needs escalating doses as they get bigger.
Agree.
Any comment on, you've mentioned nadolol multiple times now, and the data from Dr. Ackerman's lab, which is the most extensive published data, but how reproducible do you think that is outside of the Mayo Clinic?
What, using nadolol?
Using beta blockers.
Using beta blockers. Well, I certainly do use beta blockers in physically active patients and athletes, and it is harder. Sanjay is completely right. It is harder, but I do start off trying with nadolol, possibly propranolol if we're starting in children with smaller doses. But you just have to gradually edge up on it. If you start somebody on 80 milligrams once a day, you're immediately going to get into trouble, or higher than that. I would usually start. The nadolol tablets, the ones that we've got access to now, you can only do, they're 80 milligram tablets, so you can only divide in two. Dividing them into 4 is really hard, but we used to be able to get 20 milligram tablets and start gradually and build up. But that's the way I would tend to go about it, a gradual approach to what the patient feels they can tolerate and accept, because they're going to have to live with it and comply with it, as Silvia said.
Yeah, I think my take-home message from that is that the data is published in very aggressively treated athletes, very aggressively treated with either sympathetic denervation or high-dose nadolol. And it's not, let's give them 12.5 of metoprolol and send them on their way and say that you're on beta blockers and you're good to go now. It's really in an aggressive center of excellence that this is done. And I think that needs to be a take-home point anytime I talk to anyone about long QT syndrome and participating in athletics.
And I think that's why the guidance is you need to do it in an expert center, because you can't just touch the edges.
Another question that's come up a couple times is about the legality of ICDs in sporting competitions. And We'll let Rachel, I think, start with that.
Well, so this is part of where shared decision making comes in. You talk to the athlete, you say the risk is not zero, and as I say, the data that we have, there's no signal of harm, but that doesn't mean the risk is zero. And assuming that the athlete is aware of that and is comfortable with it. I thought you were going to ask about the legality. I think the question of legality of restriction is actually something in the United States that is going to now come up. Here in the U.S., we have the Knapp versus Northwestern case, in which the courts upheld the right of a school to restrict Nick Knapp from playing basketball. But that was based on the concept that the team physician has a right to restrict as long as it's based on reasonable considerations. And part of reasonable considerations was reliance on expert consensus documents. Expert consensus documents say that sports now may be considered for patients with an ICD and with hypertrophic cardiomyopathy in the recent HCM guidelines and other entities. And so, at least in the US, we haven't seen how yet who would win if a situation in which a school attempts to restrict a patient with an ICD or another condition in which guidelines state may be considered. Because the team physician it'll be a little bit harder to show that restriction is reasonable, given that the guidelines no longer support it. And so I think, at least in the United States, the legal landscape is not yet determined since the 2015 eligibility and the 2020 HCM guidelines.
We've got 4 minutes left. I thought, just for interest as well, I'm not sure about the second case, but I thought I might fill people in with it because we've voted on the cases and we may as well give a little bit of real world reference as to what happened. In the first case, we had a shared decision making that was really involved between at least two specialists and the team clinician and the athlete and his wife. And there was a decision that he could return to play after testing his device with the rigors of it's a very physical sport. And he returned to pre-season competition the next year and was best on field at the second game. And as he was walking off the field, his device went off. And that was enough for myself and the other very experienced electrophysiologist to say, that's it, you're not playing anymore. In our opinion, very strongly. So he went to the US and got second opinions from Frank Marshalinski, who said, if I ablate, you'll be fine. And from Hugh Calkins, who said, it wouldn't be unreasonable to play again. So he went back and had another shock, and then now he's retired. But it does show how difficult these decisions are when the person's in front of you. We were, I must admit, we were a bit surprised with the opinions that came from overseas as well, which forced our hand.
Sounds like you never really able to put a name on the diagnosis for that patient.
No, so our running diagnosis perhaps is some left ventricular ARVC, but he doesn't fulfil criteria, and to be honest, that's a very speculative diagnosis. He has had genetic testing, which was negative. So you're right. We don't. It could be a sort of some scar due to previous myocarditis. Very speculative. So yes. Do we have any details on the second case as to whether they returned to sport at all?
Yes. So she returned to sports, but not at competitive level. She's on beta blockers, and she is doing well actually. So, but she's a woman, so this is all, and she's doing a very low, a very not high competitive sport. She's just running 2 times per week for 2 hours. So, not a lot.
Silvia, can I ask you, did her QT reduce with the lower level of intensity of exercise?
Yes, of course, yes. Yes, it reduced. But our concern was that, as you mentioned, was about, of course, the genotype, and also the family history, because the mother was also symptomatic for syncopes during exercise. So it looked like the risk was high. So for this reason, we haven't allowed her to exercise in competitive sports.
All right, we have hit our time limit right on time. I wanted to thank Dr. Gerche, my co-chair, and our 4 expert faculty members for this great discussion. There'll be a 15-minute break, and then the sessions will resume at the top of the hour. Everyone enjoy.
Thank you, everyone. Thank you, Michael.
Thank you. Bye.
Thanks very much.
Thank you.
Take care.